picture this. You're rounding on the words, minding your own business, when suddenly, boom, your attending pivots and hits you with a rapid-fire case. The pressure's on. Are you ready for it? Let's dive right in. All right, here's the scenario. You've got a 4-year-old coming in with severe diarrhea and deep, rapid breathing. You check the labs, sodium is 140, chloride is 115, and bicarbonate is just 15. The attending looks right at you and asks, "What's the acid-base disorder?" Take a quick mental second to lock in your answer. Salam, welcome to A Little Push, 5 Minutes Medical Mnemonics. Today's explainer is going to give you the exact, foolproof tools to look that attending in the eye and answer without breaking a single drop of sweat. We're mastering a classic, absolute must-know concept in nephrology. We're talking, of course, about normal anion gap metabolic acidosis. You'll also hear it called hyperchloremic metabolic acidosis. Now, the absolute key here is the math. The gap itself, it literally doesn't change. Why? Well, it's pretty elegant, actually. The drop in bicarbonate is perfectly offset by a rise in chloride. So your calculated anion gap stays right there in that normal, happy 8 to 12 milliequivalents per liter range. Now look, we all know and love MUDPILES, right? It's the go-to for wide gap cases. But what happens when that gap is normal? We obviously need a totally different toolkit. And that is exactly where the HARDUPS mnemonic swoops in to save the day. It's the logical companion to MUDPILES. So let's break this thing down letter by letter. Kicking things off, we've got H. This stands for hyperalimentation. Think about your patients on TPN or those getting a huge amino acid load. But don't forget, H is also for chronic hyperventilation. Both of these situations push the body right into a compensatory metabolic acidosis. Moving on to A. This one packs a punch. It covers acetazolamide, that carbonic anhydrase inhibitor that just forces bicarbonate straight out into the urine. A also stands for direct acids, like taking in hydrochloric acid. And finally, Addison disease. And stick with me because we're going to circle back to exactly how Addison's does this in just a minute. Next up is R, which stands for renal tubular acidosis, or RTA. Basically, this is a whole group of disorders where the kidneys just kind of drop the ball. They either fail to reabsorb that precious bicarbonate, or they can't manage to pump out the acid properly. All right, here is D for diarrhea. Listen, if you only remember one single thing from this entire breakdown, make it this. Diarrhea is the absolute most common cause of a normal gap acidosis, period. You are just losing massive amounts of bicarbonate directly out the GI tract. Halfway there, U is for ureterosigmoidostomy. It's a mouthful, I know. It's a surgical procedure where the ureters get diverted right into the sigmoid colon. And what happens? You get this massive bicarbonate chloride exchange happening directly in the bowel wall. Then we have P for pancreatic fistulas and drainage. Reaching back to GI physiology for a second, remember how pancreatic secretions are just incredibly rich in bicarb? Well, if you're losing all that fluid through a fistula, you're draining the body's reserves fast, tossing the patient straight into acidosis. And bringing it home, S stands for spironolactone, our favorite potassium-sparing diuretic, and saline. Specifically, pumping in large amounts of normal 0.9% saline. When you infuse massive volumes of saline, you're dumping a huge chloride load into the blood. Mathematically, that chloride just drives the bicarb levels right into the ground. Section 2, High-Yield Clinical Secrets. Okay, so you've got the HARDUPS mnemonic locked in. Nice. But let's take it a step further. I want to share a few insider diagnostic secrets that'll guarantee you some easy board points. First up, the hyperchloremic clue. Think back to the formula. Anion gap equals sodium minus chloride plus bicarb. If you get a vignette with low bicarb, but you notice the chloride is high, stop right there. The gap is normal. That elevated chloride perfectly hides the dropped bicarb. It's an absolute giveaway. Next secret. Test makers absolutely love demographic clues. If your patient is a child showing a normal gap acidosis, 9 times out of 10, the answer is diarrhea. But if it's an adult, renal tubular acidosis, or RTA, is by far the more heavily tested underlying cause. Keep that in your back pocket. And finally, the Addisonian connection. We mentioned it earlier, but why does Addison disease cause this? Well, Addison's means adrenal insufficiency, a severe lack of aldosterone. No aldosterone means your kidneys can't secrete hydrogen ions in the distal tubule, and boom, that leads right to our hyperchloremic acidosis.
All right, time to really cement this. Let's do a rapid review quiz. Question 1. What is the most common cause of a normal gap acidosis in children? Think about it, locking it in.
It's diarrhea. You've got massive bicarbonate loss flowing straight through the GI tract. Okay, question 2. How exactly does a large volume normal saline infusion cause this specific acidosis? Take a few seconds. Because it introduces a super high chloride load, which mathematically drives those bicarb levels right down. Last one, make it count. Why does Addison's disease cause a hyperchloremic metabolic acidosis? Ponder that for a moment. Yup, the lack of aldosterone leads directly to a decrease in hydrogen ion secretion in the distal tubule. Honestly, outstanding job if you pulled those from memory. So look at that. You've officially mastered the normal gap, you know the underlying math, and you've got the HARDUPS mnemonic down cold. You are more than ready for that attending's question. But hey, the real question now is, are you ready to conquer the wide gap mud piles next? Keep pushing your boundaries, guys. Until next time, salam.